Very good afternoon to everybody. I'm extremely grateful to Dr. Mohan and the entire team AIG for this opportunity. I shall be speaking about early esophageal squamous cell carcinoma, focusing mainly on the IPCL classification and how to interpret it in a practical fashion. Of course, I cannot start without my acknowledgement to Professor Vedo, whose teachings have enabled me to understand so much out of this, and I'm extremely grateful to him for that. So if you look at esophageal cancers, we keep talking about early gastric cancers, but I think for us as a region, as a country, esophageal carcinoma is extremely common. It's the third most cancer among males in this country. And I think we need to focus on this aspect also. So if you talk of 5-year survival rates for esophageal cancer, in an advanced cancer, the advanced cancer survival rates are hardly 10%. But for early esophageal cancer, if you are able to detect it, it increases to 85%. So when we talk of early cancers, so in the true sense, early cancers are T1A lesions, which are limited to the mucosa. And there is also superficial esophageal cancer, which includes both T1A and T1B. That is lesions which are localized to the mucosa and submucosa. So when we look at the esophageal histopathology, there are something called papillae. So these papillae are basically projections, finger-like projections, which are going up from the lamina propria into the epithelium, right? And so IPCLs are basically the capillary loops which are present within this papilla. So IPCLs are intrapapillary capillary loops. So if you look at the esophageal microvasculature, the vessels start from submucosal vessels, from where arises these arborescent vascular networks, also called as branching vessels, from which you have this subepithelial capillary network, and eventually the third or the fourth degree capillaries are these IPCLs, whose diameter is around 7 micrometer, which is equivalent to that of an RBC. So basically these are such fine vessels where a single RBC can traverse, right? So if you look at it, these vessels on histopathology, these are where they are located. These are the branching vessels that you can see. These are the subepithelial capillary networks that will be visible as such on the histopathology. And IPCLs will be there right at the top. So these are the smallest capillaries that you can see right on the surface of the squamous epithelium. So if you look at tumor progression that occurs from a stage of normalcy to a submucosal cancer, we all are aware that there's a lot of angiogenesis that goes on. This has been proven by multiple studies where you see all these angiogenic factors going on increasing as the tumor goes on becoming more and more invasive. And this is what leads to a change in the microvascular structure because of the alterations in the angiogenesis. And this is what we intend to find when we try to look for IPCLs. So how do you look for it? We all know that when you use a white light endoscopy, white light has this entire spectrum starting from the violet to the red, and this has deeper penetrations also. So it will be focusing on all kind of vessels, not particularly focusing on the superficial vessels. So we might not be able to pick it up very, very clearly. But when you use a narrow band imaging, you are actually using a blue-green filter. And what this does, the blue-green light only goes to the more superficial layers, and it enhances the visibility of these superficial layers. So the blue light, when it enhances the IPCLs, it is reflected as a brownish colored light, and the green light, when it reflects from the more deeper vessels, which are usually the subepithelial capillary networks, they are reflected as a bluish kind of a tinge of light. So when you have done an NBI or a magnification NBI, you will start appreciating these structures. Like the branching vessels are the deeper ones, which are the bluish appearing larger vessels that you can see at the bottom. Then you have the subepithelial capillary networks, which are arising like an arborizing fashion from here. And at the end of that, you will have these intrapapillary capillary loops, that is the IPCLs, which we try and characterize when we do especially a magnification NBI. So how does this help us? right? So when you are doing an endoscopic diagnosis, it involves two steps. The first step is the detection, and the second step is characterization. So characterization involves both differentiation of that lesion into a carcinoma versus non-carcinomatous lesion, and the next step also involves the staging if it's a cancer. So we are able to perform all these functions by just looking at the IPCL patterns, right? So how do you detect an early esophageal squamous cell carcinoma? On a white light endoscopy, when you do white light endoscopy, look out for these reddish areas. So look out for these reddish areas where there's a disappearance of background vascular network. The same correlate on a non-magnification. We are talking of a non-magnification NBI. You will see these demarcated brownish area. So on white light, it's a reddish area. On NBI, it's a brownish area. And this shows us a fair sensitivity and specificity to demarcate a lesion. Why does this lesion appear brownish? So it's a brownish demarcated area. Why it appears brownish? Because it is thought that there is a thinning of the overlying keratinous layer of the squamous epithelium, which gives it a brownish hue. So you'll see a typical brownish area on NBI. Then you go to characterize and staging, and this is aided by doing a magnification NBI. When you start doing a magnification NBI, you start seeing these IPCLs in a much more detailed fashion, and then you look out for the morphology of these IPCLs. So when you look at the morphology of IPCLs, initially there was this Inouye's classification, which gave us these different types of IPCLs, starting from type 1 to type 5, and then these type 5 were again subclassified. So basically type 1 to type 5 were indicating a sort of characterization, whether we are dealing with a normal IPCL or that with an inflammation or that with a neoplasia. And once it is neoplastic, it could be subclassified to find out about the staging based on the subtypes. But then this appears quite complex usually for the beginners, and especially the problem lies when you have to differentiate whether it's an esophagitis, whether it's an inflammation or it's a malignancy, because many times these IPCLs tend to appear similar. So it's very difficult sometimes to differentiate between an inflammatory lesion versus a neoplastic lesion. What is more important to understand is that as the lesions go on progressing, you go on from dilatation of the IPCL patterns to more tortuosity, to more change of caliber, to change into a non-uniform structure. So from one structure to other. So this is the grade of hierarchy that you're looking out for, right? So the highest grade would be a non-uniformity in the structure. So now we have the JES, Japanese Endoscopy Society classification, which has made it much more simpler. So for type B1 vessels, you will need all those 4 characteristics that we discussed to say it's a B1 vessel. If it is not all 4 of those characteristics, it stands as a type A vessel. So let's look at these B vessels. So B1 is a B type vessel with a loop formation. So when you see these kind of IPCLs, you are probably dealing with a T1A lesion, which is restricted to lamina propria at the most. If you see a loss of loop, so initially you were seeing a looped pattern, now the loops have opened up. So this is probably a T1A or an early T1B lesion with a good sensitivity and specificity. And if you see a thick greenish vessel, so greenish vessel, remember, previously we were seeing brown vessels, now it's a greenish vessel. So greenish is, it's a deeper vessel. The diameter of this vessel is at least 3 times that of the original B1 vessels. So these indicate that we are dealing with a much deeper lesion, which is usually more than a T1B or a deep submucosal tumor. So the JES has made it pretty simple for us to identify these patterns. So I think we should all use that. There is also this concept of an avascular area, which was published by Dr. Arima's group, where they have tried to see for the size of avascular areas, but here again you would also try to see the vascular structures in the surroundings. So when you have appropriately characterized these lesions using the JES classification and so on, you can actually make out how the stage of the esophageal cancer, and that is very useful because that will help us in determining what would be the right treatment strategy for this lesion. So ladies and gentlemen, I think the take-home message from this should be that to diagnose and triage early esophageal squamous cell carcinomas effectively, we all need to understand and know the IPCL patterns. Thank you so much.